Bismillahirrahmanirrahim. Good morning and good afternoon, everybody. Good morning to our US speakers. A very warm welcome to all of you to our 19th Shaukat Khanum Cancer Symposium. And as we all know that this year it's not going to be the same hustle and bustle of our usual symposium, and it is going to be virtual, but we've got an excellent panel of speakers today for everybody. So I'm hoping that it's going to be a very interesting and academic session with lots of discussion. So without wasting my time, I would like to introduce my speakers today. We have Professor Frederick Smith. He's a consultant medical oncologist at Sibley Memorial Hospital and instructor at John Hopkins School of Medicine. He has a special interest in breast cancer. He's published extensively, and I'm very impressed that he's won quite a few awards. And he was named the best doctor in Washington in 2012. So we've got the best for you. Then we have Dr. Shahina Dawood. Shahina is a good friend of mine and does not need any introduction. But Shahina is also highly qualified. She trained from McGill and MD Anderson. With she again has special interest in breast cancer. She's published extensively. She's won several awards from ASCO, and she's still contributing a lot to ESCO, and she's actually changed, in my view, she's changed like the landscape of oncology in the Gulf states, and she's a leading figure, leading oncologist there. So I'm really very happy to have Shahina join me today as a moderator. Then Dr. Kamran Rashid, probably the most popular medical oncologist of Pakistan, because you'll see he's in almost every session. He's in lung and I think sarcoma and other sessions as well. So everybody wants to have Kamran join them in their panel because it's always up to date. And we will have Dr. Azmina as well. Dr. Azmina will be joining me shortly. I think she's in the clinic, but she's at the panel of experts. And so, welcome everybody. So I see Sarah Batchman. So you are joining us as well. Thank you very much. She's representing ASCO. And so I think we will start with Dr. Frederick Smith's talk today. So Shahina, you are actually the chairperson and you're the moderator. So, we'll start with Dr. Frederick Smith, who's going to talk about breakthroughs in HER2 positive breast cancer. So over to you, Dr. Smith. Thank you.
Thank you very much, Dr. Siddiqui, and I thank the organizers of the Shaukat Khanum Symposium for inviting me, and the indefatigable work that Dr. Samira Bhatt, you yourself, Dr. Siddiqui, and Sarah Bachman have done to try to put this together. I had the great privilege last year of being in Karachi at the SUIT joint meeting. And I was impressed by how much at the cutting edge of information my medical oncology colleagues in Pakistan were. Their limitation, obviously, was finances and trying to deliver this type of treatment to all the patients. So having said that, I'd like to just proceed on and bring you up to date with a review. I'm sure that my oncology colleagues, at least, are familiar with this. But my topic this morning is going to be the advances in, let me see, I'm having a little bit of a problem here. My topic is going to be in advances in metastatic HER2/neu positive breast cancer treatment. I trust you can all see my screen. Are we still together? Dr. Siddiqui?
But if you could share your slides, please. Share screen.
Okay, I'm going to go and...
We did that yesterday. So.
And share screen.
Yeah.
Okay. Here we go. Sorry about that. Here we are. So again, thank you for the invitation. And my topic this morning is going to be on metastatic HER2 positive breast cancer. So here are my contact points, and please feel free to contact me at any time. And I'd be happy to make these slides available to any of you. My email address and telephone number is listed below. So to quickly review, with the advent of Herceptin, trastuzumab in 1998, that represented a major breakthrough in treatment of this particular phenotype, which was heretofore considered perhaps the most aggressive. And then with the dramatic advance, there was a standing ovation when the adjuvant data was presented several years ago. And this was substantiated by the Mayo Clinic group, the NSABP, and the HERA studies from Europe. This morning, I'd like to quickly review Cleopatra, which was a combination of Herceptin, docetaxel, and the addition of Perjeta as first-line treatment in HER2 positive disease. Again, quickly review Amelia, which was TDM1, an antibody drug conjugate of trastuzumab for second line and beyond. But then spend the time in the most recent three entities of trastuzumab deruxtecan, tucatinib, and neratinib. So moving forward, this was Cleopatra. And what this represented was a phase 3 study adding the second HER2 blocker, pertuzumab, to what was considered at the time state of the science of trastuzumab with the chemotherapy. I'd like to observe that in the eligibility criteria, and I hope you can see my arrow, but if not, in the box on the left of the screen is that these were de novo patients who had received at the most one prior hormonal therapy and no chemotherapy for their metastatic disease. They had to have had a disease-free interval of 12 months, and they were randomized on a one-to-one basis to receive what was considered the standard of care of trastuzumab with docetaxel chemotherapy versus the same drug combination with the addition of pertuzumab. And here are the results to review. There was a 6.3-month improvement in progression-free survival, which was statistically significant. And the overall survival was also improved, as you can see here. My view of the slide is a little blocked by the image of myself staring back at me. So this 15-month improvement in overall survival led to quick approval of the addition of pertuzumab to trastuzumab for first-line metastatic HER2 positive disease. One note is that the study permitted only one prior hormonal therapy in the hormone receptor positive HER2 positive patients, not what I necessarily would practice. So then to the Amelia study. The Amelia represented the use of trastuzumab emtansine, the trastuzumab being linked to the tubulin poison emtansine, and the payload of the chemotherapy would be delivered to the intracellular space. So this study was in second line and beyond. So these patients were previously heavily treated. It was a substantial number, and they had seen taxane, trastuzumab, and potentially pertuzumab, and were then randomized upon progression to receive TDM1, or what was then considered the standard of capecitabine lapatinib on a one-to-one randomization. So the numbers were pretty well balanced. As you can see, these patients were more heavily pretreated than the Cleopatra. And the results, once again, was important in that the median progression-free survival was increased from 5.8 months with the capecitabine lapatinib to 9.4 months, a statistically significant result. I'd like to have you remember previously treated, but the median progression-free survival of 9.4 months, as we'll see what the new information package seems to portend. So the overall survival as well showed significant improvement. So at the present, the standard of care in the US is for first-line HER2 positive metastatic disease that the Cleopatra program is first line, and then subsequently Kadcyla or TDM1 is second line. Moving forward, three drugs have been approved within the past year for this entity by the FDA in the US. So the first study that I'd like to present is the Destiny study. And this was presented at San Antonio last December and represented the use of a different payload linked to a trastuzumab molecule. So trastuzumab deruxtecan. The study had two parts, but ultimately the first part was dose seeking, and it was felt that the 5.4 milligram per kilogram was the best effective and tolerated dose. So that was what was used in the part two of the study. The primary endpoint was confirmed overall response rate, and this represented patients who were previously heavily treated. And at this point, the majority, in fact, all of the patients had to seen trastuzumab, Herceptin, and TDM1, as well as many having seen pertuzumab. And in spite of this heavily treated group, the overall response rate was 60.9%. And looking at this forest plot, with this being the line of demarcation, you can see that even in previously pertuzumab treated patients, there was a good result. And this pertained all the way down the subsets that were looked at. And noteworthy is that in the HER2-neu questionable, there appeared to be about a 50% response rate. The progression-free survival was 16.4 months. And to refresh, with TDM1, it was approximately 9 months. So a significant report. The overall survival has yet to be reached. The treatment toxicities were those of adding chemotherapy to trastuzumab. So there was cytopenias as the most significant, but in general, it was well tolerated. And if I may just broadly categorize that, all the cardiac concerns of all these three drugs were similar to those of trastuzumab alone. So there's no additional signal of that toxicity. The problem that emerged, though, was interstitial lung disease. And in fact, it represented a considerable problem with 4 fatalities. And consequently, an admonition is that one be very cautious about pulmonary symptoms and the quick institution of steroids should this occur. You'll also note that if you go back and look, there has been this signal on occasion, even with trastuzumab alone, and certainly with some of the tyrosine kinase inhibitors, but this was the most striking and brought up. So the authors appropriately point out that it had a significant overall response rate in a heavily pretreated group of patients with an excellent progression-free survival of 16 months. They question about the interstitial lung disease. And ongoing is a further study of this drug against the present standard with TDM1, Kadcyla, and the other is looking at this drug in HER2 low patients. So the next drug that I'd like to present, the study was called HER2 Climb. And here the key eligibility is important. Again, previously heavily pretreated patients received trastuzumab, pertuzumab, and TDM1. But this study was kind of highlighted because they allowed patients with brain metastases, some of whom had been untreated, some of whom appeared to be progressing even whilst having been treated. And they were randomized on a 2-to-1 basis to the tucatinib, trastuzumab, capecitabine with the same trastuzumab, capecitabine, and placebo. So tucatinib is a tyrosine kinase inhibitor, which blocks the intracellular domain of HER2. The results, again, important in that there was a clear improvement in median progression-free survival, as well as at 1 year, 33% of patients on the study arm were in remission, as opposed to 12% in the comparator. The overall survival was also important in that it was 21.9 months in comparison to, my slide is hidden here, but in comparison to roughly 17 months. The important part of this study was that in their population with brain metastases, there was a benefit of adding tucatinib with a median progression-free survival that was significantly better than those who were on the comparator arm. The major toxicity, as we've noted with many of these tyrosine kinase inhibitors, has been diarrhea. Much of the diarrhea was perhaps made responsible by the capecitabine, but nonetheless, the contribution The study included patients with metastatic disease who'd had at least 2 lines of chemotherapy. Again, asymptomatic stable brain metastases were allowed, and a 1-to-1 randomization between the considered standard of lapatinib, capecitabine, versus the addition of neratinib to the same regimen. The patients were previously heavily treated, and as you can see here, the majority had seen trastuzumab as well as many pertuzumab and TDM1. They're comparably randomized. And here are the results. The median duration of response was significantly improved, 8.5 months as opposed to 5.6 months. The objective response rate, whilst better, was not statistically significant over lapatinib and capecitabine. This was the important point of the study, that those who were on the neratinib arm had a lower time to progression of their brain metastases and need for intervention in those who had not previously intervened. The overall survival was a modest 2.3 months improvement. So the investigators point out that this is, again, an important combination, superior to lapatinib and capecitabine, which might be considered a prior standard. And that, once again, the CNS control was, again, highlighted, and the duration of response of 8.5 over 5.6 months. So one of the things that I failed to point out is that the diarrhea of neratinib is profound, and consequently, from the get-go, these patients have to be on loperamide and perhaps cholesterol, and I think initiating with a lower dose. So to summarize, there's been significant continued advances in the treatment of HER2 positive metastatic breast cancer. And control of CNS metastases is important because as many as 30% to up to 50% of these patients will develop brain metastases, and that should be thought of in selecting these drugs. There's more information on that trastuzumab deruxtecan to come. They're the randomized studies that I showed, and the tantalizing thought that it might help even the low HER2 new expressors. So we'll see more about that. And we'll also see more such antibody drug conjugates with trastuzumab. So I can say now that this feared HER2 new positive entity may be becoming almost like hormone receptor positive metastatic breast cancer as a chronic illness. As Dr. Siddiqui and I chatted a few days ago, we have patients on trastuzumab-based therapies with metastatic disease still doing well, not just months, but years into the course of the disease. So thank you very much again for the opportunity of presenting this to you. And I am happy to share any of this with my colleagues. Thank you, Dr. Siddiqui. Thank you, participants.
Thank you very much, Dr. Smith. Really exciting, breakthroughs in HER2 positive breast cancer. And we will be discussing these when we have the, Challenge Your Expert session. So I will now request Dr. Shahina Dawood to please start her presentation. And if for the audience, if you have or people who are seeing this session, please, if you have any question, do send us those, and we will try to answer all the question or as many as possible towards the end of this session. And remember, we have a second session also. So let's hear from Dr. Shahina first, and then later on we can have a bit of a chat about all these new therapies. So Dr. Shaina is going to talk about hormone receptor positive breast cancer, and she's going to tell us the recent updates.
Thank you,
Shaina.
Neela. Thank you for the lovely introduction. So I don't think that there's been like major updates in 2020. I think there's been only one or two things that have been really major. So what I thought I would do was to answer some simple questions that I think have frequently come up in the clinic, especially in our part of the world, in Asia and Middle East. Looking at both patients with hormone receptor positive early stage breast cancer as well as metastatic breast cancer. So these are my disclosures. And as you know, let me just put this like this. As you know, we've seen from the early breast cancer trial as collaborative group that the effect of 5 years of tamoxifen on the 15-year probability of recurrence and death from breast cancer has been significant, with an improvement in recurrence-free survival of absolute benefit at 15 years of about 13.2%. And then, of course, a benefit in terms of breast cancer mortality at 15 years of 9.2%. We've seen also from the early breast cancer trial as collaborative group that 5 years of an aromatase inhibitor versus 5 years of tamoxifen aromatase inhibitor improves the 10-year absolute recurrence-free survival by about 3.6%, and of course the breast cancer mortality by about 2.1%. So I think there's been three main questions that we've addressed in 2020, but really dating it back to the last couple of years in the early stage setting. And the first, which is the most important, I think, for our part of the world, is should all premenopausal women with ER positive breast cancer actually receive ovarian function suppression in addition to standard adjuvant therapy? And I think when you're looking at this question of role of ovarian function suppression, there's three main trials that you need to look at. There's a meta-analysis, the ECOG 3193 trial, and of course the SOFT trial. The meta-analysis, which came out in the Lancet in 2006, actually was an individual level patient data retrieval of different trials that looked at the addition of an LHRH agonist to tamoxifen and found that it reduced the risk of recurrence by about 12.7% and the risk of death by about 13.6%. Really asking the question, do all premenopausal women in fact require ovarian function suppression? That led to the ECOG 3193 trial. That was a phase 3 clinical trial that took 345 patients premenopausal, randomizing them to either tamoxifen or tamoxifen plus ovarian function suppression. No one received adjuvant chemotherapy, and you can see that the Kaplan-Meier curves are practically overlapping each other. This trial also had early closure and didn't really answer that question if certain subgroups could in fact benefit. We then saw the results of the SOFT trial that randomized patients who were premenopausal to either tamoxifen or endocrine therapy plus ovarian function suppression. And you can clearly see that adding ovarian function suppression amongst premenopausal women with breast cancer significantly improved the 8-year survival rates, both in terms of disease-free survival, as well as a trend towards overall survival when you're comparing it to tamoxifen alone. And when you stratified it by chemotherapy, you can see that the addition of ovarian function suppression to tamoxifen versus tamoxifen actually improved the absolute improvement in 8-year breast cancer-free interval of about 5.3%. So this really, collectively, the data indicated that a subset of high-risk premenopausal women, in fact, do require ovarian function suppression, which then led to the question, are aromatase inhibitors, in fact, better than tamoxifen when combined with ovarian function suppression amongst patients who are premenopausal? And the three trials to consider here are the SOFT text and the ABCSG12 trial. And you can see in the combined analysis of the SOFT and the text trial, when you looked at AI versus tamoxifen, of course, in combination with ovarian function suppression, you can see that the use of exemestane plus ovarian function suppression resulted in even higher rates of freedom from recurrence. Now, to put that into context, we have the ABCSG12 trial, which did not allow premenopausal women to receive chemotherapy. These were early stage patients. They did undergo ovarian function suppression, randomized to receive either tamoxifen or anastrozole plus amionous zoledronic acid. And in terms of tamoxifen versus anastrozole, you can see that there was practically no difference in terms of the Kaplan-Meier curves. However, despite this data, looking at the SOFTEX trial, a lot of international recommendations are present that you can use an aromatase inhibitor in patients who are young and at high enough risk to warrant the use of ovarian function suppression plus an AI. The next question is, who requires chemotherapy in the node negative setting and the early stage setting? Now, I think this was a very important question because in the last couple of years, including 2020, we've seen a lot of data come out from the TAILOR-X trial. And just to put that into context, the TAILOR-X trial was a prospective trial that looked at Oncotype DX in terms of stratifying patients in the node negative setting into either low risk, intermediate risk, or high risk. When you looked at the patients who had low risk, and this constituted about 15.9% of patients, you can see there's practically no benefit in terms of giving chemotherapy. And if you look at the 5-year invasive disease-free survival and 5-year overall survival, it's very good at 98%. When you looked at patients at high risk with a recurrence score of between 26 to 100, and you look at the table over here, and remember this constitutes about 14% of patients in terms of freedom from recurrence of breast cancer at a distant site. when you gave chemotherapy, this resulted in a 5-year estimate of about 93%. And when you compared this to data derived from the NSABP 20 trial, you can see that if you, in fact, did not give chemotherapy, the 5-year distant disease free survival would be about 78%. So, giving chemotherapy plus endocrine therapy in this group was very important. Now, the most controversial group was, in fact, the intermediate group, which constituted about 69% of patients. And the recurrence score was from 16 to 25. And you can see that if you looked at the whole cohort as a whole, there was really no difference between giving chemotherapy plus endocrine therapy versus endocrine therapy alone. But when you substratified based on the age of the patients and you looked at those patients who were younger than age 50, you started to see some benefit from chemotherapy. And a recent publication in the New England Journal of Medicine actually substratified these patients not only based on their recurrence scores and their age, but also on whether they had a high clinical risk or a low clinical risk. And you can see that in terms of an absolute benefit from chemotherapy amongst patients who had a recurrence score of between 16 to 20, if they had a high clinical risk, it would be about 6.5%. And if they had a recurrence score of 21 to 25, you can see that the benefit was also about 6.5%. So this is really a conversation you need to have with your patients who are younger than age 50, which really constitutes a large cohort of the patients that you actually see in the Middle East and Asia. And then, of course, this year at ESMO, we saw the question of what is the role of adjuvant CDK4/6 inhibitors. Sorry. And this was presented at ESMO in terms of two important clinical trials. We saw the PALACE study, which is a phase 3 open label study looking at patients with stage 2 or 3 hormone receptor positive HER2 negative breast cancer who were randomized after they'd finished their adjuvant or neoadjuvant therapy to either palbociclib plus endocrine therapy or endocrine therapy alone. And in terms of the primary endpoint, in terms of invasive disease-free survival, you can see, again, the Kaplan-Meier curves are practically overlapping each other. There was no significant difference. And when you looked at the distant relapse-free survival, again, no difference between the two cohorts. The second trial that we saw was the Monarch E trial, again, that took patients hormone receptor positive, HER2 negative, high risk early stage breast cancer. But in this particular trial, they restricted it to very high risk group of patients, patients with more than 4 lymph nodes that were positive, or patients that had 1 to 3 lymph node positive and had at least one of the 3 risk factors, which included tumor size more than or equal to 5 centimeters, a histological grade of 3, or a Ki-67 of more than or equal to 20%. Again, after they'd completed their therapy, they were randomized to receive either abemaciclib plus endocrine therapy for 5 to 10 years as clinically indicated, and the endocrine therapy and the abemaciclib here was given for 2 years, or standard of care endocrine therapy, which was again given for 5 to 10 years as clinically indicated. In terms of the primary endpoint of the trial, you can see the trial was a positive one in terms of invasive disease-free survival. The 2-year invasive disease-free survival was 92.2% for patients who received the combination of endocrine therapy plus abemaciclib versus 88.7% for patients who received endocrine therapy alone. This translated into an absolute 3.5% difference in terms of invasive disease-free survival, favoring the group of patients who received the CDK4/6 inhibitor. Similarly, when you looked at the distance relapse-free survival, there was a 3.3% absolute difference in terms of favoring the group of patients who received endocrine therapy plus abemaciclib. Now here I'm just comparing the two adjuvant CDK4/6 inhibitor trials, the Monarch E and of course the PALACE trial. And really, the key differences between the two trials is the fact that Monarch E, in fact, had a high risk group of patients. Everyone had to have node positive disease, while PALACE did have about 13% of patients who had node negative disease. Irrespective of that, when you looked at patients who had invasive disease, when you looked at the clinically high risk group of patients, the invasive disease free survival hazard ratios was 0.75 for Monarch E and statistically significant, while for PALACE it was 0.89. And when you specifically focused in those patients who had more than 4 lymph nodes that were positive, again, that really, really high risk group of patients, it was 0.69 for Monarch E, again, statistically significant. But when you looked at the PALACE trial, trial, again, it was not different. It was 0.89, and again, not significant. You can see the confidence intervals, in fact, crosses 1. We've seen from a press release that the Penelope B trial is going to be presented at San Antonio, and it has been shown to be a negative trial. The Penelope B trial took patients with hormone receptor positive disease. They all received neoadjuvant chemotherapy, following which they underwent surgery, and those with residual disease were randomized to receive palbociclib plus endocrine therapy or placebo plus endocrine therapy. And although we await the results of this trial that will be presented at San Antonio, as I mentioned, it has been in a press release shown not to be a positive trial, really asking the question, if it's all about high risk, then why is Penelope B in fact a negative study? But what do I do in my clinic? In my clinic, patients with stage 1 to stage 3 hormone receptor positive breast cancer, and here I'm going to focus only on the algorithm of patients who are premenopausal because that's what we typically tend to see in our part of the world. Those with node negative, HER2 negative patients with a recurrence score of less than or equal to 15, they have tamoxifen for 5 years. We may consider in some of these patients to extend it to 10 years based on the Atlas and ATOM trial. Those who have a recurrence score between 16 to 20, again, node negative, they get 5 years of they get 5 years of endocrine therapy, and we may consider ovarian function suppression in these patients. Those who've got a recurrence score of more than 20, we do have that conversation about chemotherapy, depending on the recurrence score that you're looking at, 5 years of ovarian function suppression plus endocrine therapy. And of course, if they're node positive, recurrence score is not done, and they receive chemotherapy, 5 years of ovarian function suppression plus endocrine therapy. If they are age less than 35, and AI is preferred. If premenopausal, at the end of 5 years, we do tend to continue with tamoxifen. If postmenopausal at the end of 5 years and they have not received 5 years of an AI, we may consider switching to an AI. And if postmenopausal at the end of 5 years and they've received 5 years of an AI, we may extend AI therapy based on the risk factors. And based on the recent results of the Monarch E trial, we do in our multidisciplinary tumor ward, we consider each case individually, and we do consider adjuvant abemaciclib in those patients who have more than or equal to 4 positive lymph nodes. Now, shifting gears to the metastatic setting, in patients with first line and patients who are treated in the first line setting with endocrine therapy, hormone receptor positive, we know that tamoxifen results in a progression-free survival of approximately 6 months. We know that aromatase inhibitor trumps tamoxifen with a PFS of about 14 months. We know based on the Falcon trial, fulvestrant results in a PFS of 17 months, but with the recent integration of CDK4/6 inhibitors in the first line setting, we know the combination of CDK4/6 plus an AI results in approximately 28 months in terms of progression-free survival that results or translates into about a 50% reduction in the risk of progression of disease above and beyond that of an aromatase inhibitor alone. So 5 main questions that we've asked ourselves in 2020. Could fulvestrant be enough in the first line setting among patients without visceral metastases? And this question arose because we've seen from the Falcon trial that although fulvestrant trumps anastrozole amongst patients without visceral metastases, and fulvestrant has a median progression-free survival of about 22.3 months. So a really huge progression-free survival compared to anastrozole of 13.8 months. So this year at ESMO, we saw the results of the phase 2 trial of the Flipper trial, which randomized patients to receive either fulvestrant or fulvestrant plus a CDK4/6 inhibitor, palbociclib. And you can see in terms of the whole cohort, again, when you combine CDK4/6 inhibitor plus palbociclib, it trumps fulvestrant. But more importantly, amongst patients with visceral metastases or those with no visceral metastases, combination endocrine therapy does trump single agent endocrine therapy with fulvestrant. So again, even in those patients without visceral metastases, combination endocrine therapy is superior. What is the best endocrine therapy partner with a CDK4/6 inhibitor in the first line setting? Should it be fulvestrant or an AI? At ASCO this year, at 2020, we saw the results of the phase 2 Parsifal study, which took patients endocrine sensitive, first line patients, metastatic setting, hormone receptor positive, and randomized them to receive either fulvestrant or palbociclib versus letrozole plus palbociclib. And you can see in terms of the progression-free survival, the Kaplan-Meier curves are practically overlapping each other. There is no significant difference between the two, although there was a suggestion of a trend towards superiority with letrozole plus palbociclib, a question that we can discuss in the panel discussion. The next question is there a survival advantage to using a CDK4/6 inhibitor in the last 2 years? The simple answer to this question has been answered, and the simple answer is yes. We saw that in the endocrine sensitive cohort, the Mona Lisa 7 and the Mona Lisa 3 trial that randomized patients to either endocrine therapy or endocrine therapy plus ribociclib, you can see a clear-cut survival advantage to combination endocrine therapy that results in a 30% reduction in the risk of death from disease. And then in the endocrine resistant cohort, we've seen the results of the Paloma 3, Monarch 2, and Mona Lisa 3 that shows that a combination endocrine therapy with a CDK4/6 inhibitor plus fulvestrant in the endocrine resistant cohort does improve overall survival. The next question is, can we use CDK4/6 inhibitors among patients with HER2 positive, hormone receptor positive metastatic breast cancer? Question that we've asked ourselves several times but never really been able to answer. Last year at ESMO, we saw the results of the Monarch HER trial that took patients who are hormone receptor positive, HER2 positive, who had failed multiple lines of therapy and randomized them to receive either abemaciclib, trastuzumab plus fulvestrant, or abemaciclib plus trastuzumab, or chemotherapy plus trastuzumab. And what you can see from the Kaplan-Meier curves here in terms of progression-free survival, that if you gave a combination of abema, trastuzumab plus fulvestrant in terms of progression-free survival, it trumped giving chemotherapy plus a trastuzumab. You can see the median progression-free survival was 8.3 months versus 5.7 months. And when you compared abema plus trastuzumab versus chemotherapy plus trastuzumab, there was practically no difference. And so the authors concluded that the results in fact suggested that a chemotherapy-free regimen might potentially be an alternative treatment option for patients with hormone receptor positive, HER2 positive advanced breast cancer, although I think we do still need further data to clarify this situation. And then the final question is, what other agents are available in the endocrine resistance setting? We know that we have results from the SOLAR-1 trial that looked at patients who had PIK3CA mutated hormone receptor positive advanced breast cancer, and then randomized these patients to receive either alpelisib plus fulvestrant versus fulvestrant alone. Initially, we had seen that there was an improvement in progression-free survival, 5.7 months versus 11 months, favoring the group of patients who were receiving alpelisib plus fulvestrant. This year at ESMO, we saw the updated analysis looking at the overall survival, and there was a significant, there was a trend towards improvement in terms of overall survival. For me, this was a clinically significant improvement from 31.4 months to 39.3 months. However, in terms of statistical improvement, this was not significant. And you can see specifically amongst patients who had lung and liver metastases, the improvement was about 14.4 months in terms of event-free probability at a hazard ratio of 0.68 that was presented at ESMO this year. Now, one of the questions that came up with the SOLAR-1 trial was that most patients had not received prior CDK4/6 inhibitors. Would alpelisib work amongst patients who had received prior CDK4/6 inhibitors? And at ASCO this year, Hope Rugo presented the results of the BYLieve trial, in which it was a multi-cohort trial, and cohort A was presented where all patients had received prior CDK4/6 inhibitors plus an aromatase inhibitor, and then went on to receive alpelisib plus fulvestrant. And you can see that in this particular study, the median progression-free survival was 7.3 months. So again, suggesting that this combination does work after progression on a CDK4/6 inhibitor. What about some other agents that you can use in the endocrine resistant setting? We've seen data previously from the Olympiad and Embraca trial that amongst patients who have germline positive BRCA mutations, that a PARP inhibitor does trump physician choice of chemotherapy. Last year at San Antonio, we saw the results of the plasma match trial that looked at patients with hormone receptor positive disease who had acquired mutations over time. And for me, the most important was the patients who had acquired a HER2 mutation, where you can see some significant activity when you give a combination of neratinib and plus fulvestrant, similar to what we saw in the Summit basket trial. So this is my last slide. This is the sequence that we typically tend to use at my clinic in patients with endocrine sensitive disease. They start off with using CDK4/6 inhibitor plus an AI. When they progress, we test for the PIK3CA status. If they've got a mutant status, they get alpelisib plus fulvestrant. If they're wild type, they'll get fulvestrant alone, plus or minus everolimus based on the precog data. And then when they progress, we do test for those other targets, such as BRCA, and if they're positive, they would be candidates for PARP inhibitors. If they've acquired a HER2 mutation, we do offer a combination of neratinib plus fulvestrant. And then, of course, if there's any clinical trial, they may be able to enroll in those clinical trials. And then, of course, in the third line setting, chemotherapy would be an option for these patients. Thank you very much.
Thank you, Shahina. That was extremely informative. So I think I would request uh, all the panelists to please, if you could, yeah, put your videos on. We're still waiting for Dr. Azmina. I think she's stuck in traffic somewhere. And so Dr. Frederick Smith is there. So, Azmina, that was really interesting. Maybe you could start the, we were going to sort of ask our panelists a lot of questions. I will ask you a few later on, but you could, because I'm actually, interestingly, I made two cases and they're both relevant to your talk, so we could probably discuss it during the cases. But remember, we were talking about all the updates in HER2 positive breast cancer. Obviously, the situation here for us is slightly different. We are not able to give all the medication, and that's what I keep hearing from my colleagues in US or UK, that how do you manage. But still, we do have training programs here. We have a lot of interest in being up to date, and and we are hoping that with time, maybe with availability of biosimilars, and the prices will go down. And I remember the time when even taxines we had to apply for because it was expensive, and now we are like giving it like water. So if we leave the cost aside, because I know I'm getting a few questions about that, I think the most important is to be able to give the targeted agent for HER2 positive, that is trastuzumab, in the curative setting, that means in the adjuvant setting, because we're trying to cure. Obviously, but if you look at the metastatic, the whole profile of metastatic breast cancer has also changed. So, like in your clinical practice, Dr. Smith, you said that you're using, going by the Cleopatra and the recent updates. What about patients? What about the Catherine study? We didn't hear about that because of the time. So if you have a patient who's got like a heavy load of breast cancer, gets diagnosed, you give neoadjuvant chemotherapy, and then there is a pathological CR. What do you do then? And if you have residual disease, how do you go about it? We know about the Catherine study, but maybe you can, like just give us some sort of an idea.
As I mentioned earlier, Dr. Siddiqui, again, I was extremely impressed by Dr. Dawood's command of the information and her being at the very cutting edge with telling us what San Antonio is going to be presenting to us. So I learned quite a bit, Dr. Sheena. Thank you.
Yeah.
So in terms of the Catherine study, I was going to discuss some of that in my plenary session about escalate, de-escalate. So the Catherine study took patients who received neoadjuvant therapy and then were randomized to continue with trastuzumab alone or TDM1.
Louder, yeah.
And that proved to be a positive trial in favor of TDM1. with a significant improvement in reduction in events. So, what our present, at least my present stance is that if we get a complete remission with neoadjuvant therapy, I am just going to continue with trastuzumab. Perhaps with Perjeta, depending upon how our patients tolerated the trastuzumab Perjeta. No cardiac signal, but a fairly substantial um, gastrointestinal abdominal symptomatology. And in fact, what I will hope to show is that when we look at these neoadjuvant studies, and I was told by a surgical colleague of mine who has visited Lahore at, I believe, a private institution, but has also visited the Shaukat Khanum, Dr. Colette Magnan, who's a surgeon, is that perhaps because they're youthful patients, there is perhaps more neoadjuvant treatment than we would do, for example, in our non-HER2 positive patients. I don't know. It's a question for Dr. Dawood. But the point is, when you look at these neoadjuvant studies, take NeoAlto. If you looked at NeoAlto, there was about a 10% increment with the dual Herceptin lapatinib. So I think lapatinib has unfortunately been poorly marketed and forgotten, and may be something that, with your financial constraints, should be considered. So when you look at neoadjuvant therapy, yes, it makes the disease more operable, may improve the cosmetic result. Patients who get pathologic CRs do better than patients who don't. But the overall survival from way back prior to Herceptin was questionable. And when you take NeoAlto to Alto, which was just the adjuvant use, no benefit. Although, again, if you scrutinize the data, there was about a 1% to 2% benefit. It just did not meet statistical significance. So now the Perjeta neoadjuvant therapy, strongly 80% pathologic CRs, and as yet no survival advantage. When you look at Affinity, which was the adjuvant application of pertuzumab, once again, a very modest, albeit deemed statistically significant benefit of adding pertuzumab to that combination. So I think in resource limited situations, my colleagues there in Pakistan are more knowledgeable, inventive, because they have to be. But here in the US, we use Perjeta neoadjuvant and then TDM1 if they have residual disease. If they don't, I don't use TDM1.
Okay, thank you. So, Shahina, what about you? If you have somebody, like multiple lymph node positive, you give Herceptin and pertuzumab with chemotherapy and get a pathological CR. Would you continue pertuzumab in the adjuvant setting as well, or would you just give trastuzumab?
So, I'm going to talk ideal. I'm not going to talk cost or
Yeah,
constraint.
just
But in my opinion, if something works and it works very well, you should continue. So if I've given pertuzumab and trastuzumab in the neoadjuvant setting for someone who's got lymph node positive disease and they attain a pathological complete response, I will continue pertuzumab and trastuzumab for that 1 year as well and just complete it. Of course, you can always make the argument that if someone's attained a PCR, why continue pertuzumab and just give trastuzumab for that year? My counter argument for that is then why give trastuzumab for a year if you've attained a pathological complete response? I think if something is working and it's working very well, one needs to continue and complete that 1 year. But I have a question, if you don't mind me asking, Dr. Neelam, to Professor Frederick. Now that we are, and Neelam just alluded to this question, we're using TDM1 in amongst patients who have residual disease, and these patients do relapse. In the relapsed setting, where are you going to place TDM1 in those resistant patients? Because now you can't use it anymore. You've used TDM1 in your patients with residual disease. Say 1 year later they relapse. Where does TDM1 fall in that algorithm of metastatic disease?
So I think Dr. Sheena, thank you for the question. I think that these new studies, particularly the trastuzumab deruxtecan, is very persuasive. You recall the patient selection was all of them had previously received TDM1. So, in fact, I do encounter and have encountered such patients and go directly to what has been marketed as Enhertu, the trastuzumab deruxtecan. So that's what I would do. There will be a head-on comparison as to TDM1 of the trastuzumab deruxtecan, and that'll be interesting. But now we have these choices, and that's terrific. And I think that there's more to come.
Yeah, absolutely. Yeah, go ahead, Dr. Nina.
No, Kamran is wanting to say something, so maybe he can join the conversation.
We have two world-renowned experts sitting, giving their opinions. I'm also listening to what they have to say. Just one question, Dr. Shahina. I have a question. I have a triple negative breast cancer patient. I see them quite often, and they presented just with brain metastasis. All they have is just brain metastasis. You scan them, you do a PET. There is disease nowhere else. My question to you is, how would you treat these patients? They're triple negative and disease nowhere else.
So this is a first line setting. This is not a recurrence.
Yes. This is the first line setting. No, nothing has been given in the past.
Okay, so I mean, it really depends on how extensive the brain metastases is. If it's a solitary brain metastases, I tend to treat them as if they're early stage, and we resect. We have a very good neurosurgeon that actually resect these patients in terms of removing the brain met, and then we obviously triple negative breast cancer patients, most of them will receive neoadjuvant therapy, and at the end of their neoadjuvant therapy, we monitor their brain very well. And if we see any recurrence, then we know that that's the way to go. You have to treat them as metastatic. But if they're holding very well, we treat them as early stage, and we just monitor the brain very, very well.
But the question is, if they have extensive disease, you radiate the brain, and then you give them chemotherapy or not?
If they've got extensive disease in the brain, these patients do very badly in the triple negative setting. Yes, for sure, you will radiate if there's no role for more localized therapy. And yes, I mean, if the patient still has a breast tumor, you have to give them chemotherapy to control that breast tumor.
So Shahina, you wanted to say something, right?
It's just that we're I'm in the habit of creating these algorithms for our team over here, and I wanted to just go back to that TDM1 question. And the reason why we asked this is because we've had a couple of cases recently where we've given that 14 sessions of TDM1 in the adjuvant setting, and then you have a patient after 14 sessions that's relapsed at 6 months, and then you have another patient that's relapsed at 1 year or after that. So do these cutoffs also make any difference in terms of the type of treatment that you would give in terms of those durations?
And also to that, I'll add that, what is the role of neratinib in that setting? Patients who had TDM1 or pertuzumab.
So, Dr. Sheena, I think the fact is that you could return to TDM1, particularly if there's been a long interval between last exposure to TDM1 and relapse. And again, if there are limitations for other reasons, I think it's perfectly legitimate because it's, a very well, relatively speaking, tolerated drug. There is neutropenia, there is neuropathy, etc. So I think that's perfectly acceptable. But I think now that we have the luxury of these other treatments, I would say, particularly if the patient's relapsing within 6 months, why not move on? In terms of neratinib, one of the things that I'm going to bring up in the plenary session is that I think lapatinib was poorly evaluated and marketed. I think neratinib is probably a better drug, but I will show you that the cost difference here in the US is extraordinary, and lapatinib is about to go generic, and the cost difference will be even more. So neratinib has, and I've used it, has significant, profound diarrhea at the dosages that were chosen. So I tend to be kind of, and neratinib is a drug that was evaluated for a decade before it finally found these niches in the extended adjuvant setting and in the metastatic setting. So I tend to be hesitant to pick that up. I think oral, it might be appealing, but in terms of patient acceptability, it's not as good as certainly as the trastuzumab, as Kadcyla, TDM1, or trastuzumab deruxtecan. Tucatinib is in between that. All these tyrosine kinases have diarrhea as a significant problem. Tucatinib was combined with capecitabine, which is also a very diarrheogenic agent. So my algorithm to follow Shahina's presentation would be, yes, you can pick up TDM1, but I favor going to trastuzumab deruxtecan and then going down that procession. As you had mentioned, Dr. Siddiqui, we do have these HER2 new positive patients who are doing well for months and years. I have a lady who presented with hormone receptor negative bone metastases at presentation. She's been on trastuzumab alone after initially receiving Taxol trastuzumab now for 4 years. And she has no evidence of progression of disease. The temptation is, why not stop the trastuzumab? But it's difficult, as Dr. Shahina would perhaps comment on, she's doing well. She's doing so well. It used to be an ugly disease, death for sure. How can we stop? So I think that there lies, some of the problem of cost containment, even in the U.S.
Yes. So I think there are some outliers. Like I have a patient 10 years ago. She came with stage 4 pulmonary metastasis and HER2 positive. So she has been on Herceptin, and she could initially afford pertuzumab, and also it was early days at that time. And so there have been periods in between her cardiac function declined. I had to hold trastuzumab for a couple of months, and the disease was under control. But like 5-6 months, then it comes back. So as you said, it's difficult to stop. Then I would add, so like she's still with me, and only very recently, after 10 years, she had some progression. But in between, I would give her chemotherapy, then go back to trastuzumab and pertuzumab, and even holding the targeted therapy because she wanted a break because of cost and just getting fed up of chemo. So sometimes you can give chemo holidays, even in HER2 positive, but you know that the disease will come back, and the patient knows that it will. So then it becomes easy if the patient understands. Yes, Shahina, you say.
That's
Well,
right.
no, I completely agree with both of you. I mean, I have a patient currently right now, 4 years on TDM1, and I'm not going to stop it. He's
Yes.
doing very, very well. And he even developed a solitary brain met. We sent her for SRS, and she's still continuing on TDM1. You feel uncomfortable stopping these patients. But of course, if the patient wants to stop at a certain time point, it's a discussion that you have to have with them. I've actually, while you guys were talking, just very quickly put together an algorithm for the metastatic setting. I wonder if we can just go through it together. Maybe that would be, is that
Sure.
okay? Noor? Can I share
Sure.
that
Yes.
slide?
And after that, I'll just run by the cases. Yeah.
Yeah, so I'm just going to show this slide. So, and you can chip in anytime to see what you think of it. So patients with early stage HER2 positive breast cancer, they receive anti-HER2 therapy. And then of course, if they relapse, if the DFS is more than 12 months or they're stage 4 de novo disease, we give them pertuzumab, trastuzumab plus taxane, then go down that, algorithm that you talked about with TDM1. If once they progress, if they have no CNS disease, trastuzumab deruxtecan, and then of course tucatinib-based therapy. But if they have CNS disease, we opt for tucatinib-based therapy and then for trastuzumab deruxtecan. And then of course, once they've progressed on everything, it's dealer's choice. If they have a DFS of less than 6 months and they haven't received TDM1 in the adjuvant setting, we do opt for TDM1 and then they follow that algorithm. But if they have a DFS of less than 12 months post TDM1, like you said, we just connect with that part of the algorithm that takes us to trastuzumab deruxtecan or tucatinib. And then, of course, I have a special interest in patients with CNS Mets. And if a patient only relapses in the CNS, it's local therapy for solitary Mets, and then you can consider TDM1 or tucatinib based on what you see. So, thoughts?
If I had the money, I would give to Kaepernick for brain mets, definitely. The data is too impressive. So, but it's excellent. It's brilliant. I think if we had the
that,
we would do that.
that is a brilliant algorithm. I think it's, I'll buy into that 100%. The only caveats are two, one of which is the Cleopatra study. You know, to me, particularly if it's cost issues or if the clinical situation is not a visceral crisis and it's strongly hormone receptor positive, so it's a luminal B HER2 positive, I exhaust the hormone pathway first.
Then I do the same thing.
Then move on to Cleopatra as designed. The next thing is, again, thinking in terms of Pakistan and the cost issues, which we are now facing to a certain extent. I think that lapatinib is unfortunately forgotten. There was CNS signaling with lapatinib, so it is something that you could consider picking up in the situation where you cannot get the other drugs. And the other thing that Dr. Shahina hasn't put in here is the neratinib. The tucatinib, pertuzumab, and tucatinib, trastuzumab, and capecitabine is pretty diarrheogenic because it's got both the TKI and the capecitabine. And it still mandates trastuzumab. The NALA study is neratinib and capecitabine. And that is even more profoundly diarrheogenic, but they're oral. So unfortunately, the expense is an issue and does come in there, but that would be a consideration that might be entered somewhere along this algorithm.
In Pakistan, in our algorithm, what we do is we don't have tucatinib available. So on Herceptin and Perjeta, if somebody develops brain metastasis, we have lapatinib available. So that's what I do. I use lapatinib with capecitabine.
Capecitabine, yes. Yeah, I would do this.
For us, it's really, it's not a question mark for us,
No, Dr. Rashid, you're right on. Again, in my plenary session, which I'm going to have to modify because Dr. Shahina did such a splendid job all the way through. Because some of the de-escalation is talking about, look at the subsets. You don't have to use this soft data for the majority of these patients. I was going to present very briefly the Taylor RX, but I think lapatinib should not be forgotten just because it was underdeveloped and undermarketed. Clearly, I think the NALA study shows an advantage to neratinib, but it's exorbitant. Even here, it's exorbitant. Tucatinib.
Thank you. Yeah. Sorry. Yeah.
So you're right on, Dr. Rashid. I would use lapatinib.
Okay. Okay. So Kamal, we're going to have just very quick cases because I'm getting messages from some people that a little bit time left. So I think I'll just quickly share my slide. Very simple cases, and actually Shahina has covered that as well. So I need to just go to my here. Yeah. Okay. So just very quickly, we have probably 7 or 8 minutes left, but because we have a break of 10 minutes after that. So the first patient is a 35-year-old school teacher. She comes with the breast lump. Biopsy shows IDC, and she has breast conservation surgery. The pathology shows it's a 0.4 cm tumor Grade 3, ER 30%, PR 0%, and HER2 is positive by FISH. So she has a HER2 positive disease, and sentinel lymph node biopsy is negative. Her metastatic workup is negative. And so the questions are really for the fellows and trainees, just to sort of wake them up, because I know that not many of them can't concentrate. So they know that it's very early stage disease, T1A tumor, and what is the estimated risk of recurrence and what would you advise next. So what therapy? Kamran, maybe you can just give, because we're running short of time.
It's less than 0.5 centimeters, so I will not offer her chemotherapy and trastuzumab. I'll just treat her with the radiation with the endocrine treatment. That's what I would suggest. It's too small.
But it's HER2 positive.
I know. That's
So the risk of relapse, I think, is quite small. And we have these guidelines that the National Cancer Center network has put together. And like Dr. Kamran, they would say that less than...
okay. So that's so the discussion points are really,
Right. Less than a T1B should not be treated. However, there is, the grandfather now of trastuzumab for me is a Dr. Dennis Slayman, and he says any HER2 positive disease is bad news. And now we've got, the Dana-Farber Center looking at lesser chemotherapies. So why not? Again, Dr. Sheena would say this is a young lady, right? You've got to have the discussion. You've got to walk the walk. But I would totally agree. An older patient, no. A younger patient, the discussion, and then proceed from there.
So, that's the idea, that these are the patients. Those who are advanced stage, it's very easy to make decisions. You can, just, but the patients who come with very early stage disease, and then you have to individualize. Although, generally speaking, as you said, very small tumor, yes, we could argue that, and even NCCN guidelines, I think it says more than 0.5 when you want to start therapy. So essentially, this is something I thought I put this together, that if you have early stage disease, even if it's stage 1A, some people would, because in this case, Shaina, you can chip in whenever you want to. Then I would say that surgery and adjuvant therapy, and I would give her trastuzumab. If it's hormone receptor positive and slightly bigger tumor, up to T2 and 0, again, you give chemotherapy, you could give pre-op, or you could give surgery first. And if I would give anthracycline base, because in our setting, we tend to always use anthracycline. We're not sure whether we'll get trastuzumab or not, and then go to dual blockade. And anything above that, T2 and 0, then go to dual blockade. Pre-op, somebody asked a question. We are giving, the hospital does give it to a certain number of patients. So we are giving in neoadjuvant setting those who are lymph node positive, trastuzumab and pertuzumab. And if it's T1, 4 or to 4 lymph node positive, then I would continue trastuzumab and pertuzumab. So if any of you wants to disagree.
I completely agree. I also have an algorithm for this if you want to see it.
Oh, I know it's you and your algorithm. So this is a very simplified algorithm.
Just one modification, and that is,
yes,
I would probably, for that category A, I would probably limit trastuzumab to 6 months as opposed to a year. There's, I think.
This is the next question. Yes, okay. I'm coming to that. So yes, so because it's so early stage disease, do you want to just do 1 year? That was like a general sort of thing. But how do you balance risk versus benefit in a very young patient? Do you want to give her anthracycline, or to think of the cardiotoxicity and other, lifetime risk of anthracycline, the chemogenic? And the other thing was, as you said, Professor Smith, that could we give a shorter duration of trastuzumab? I would certainly give, but is it the FinHER like 9 weeks or 6 months. I think there is more data on 6 months. So, like if there's a concern about the cost, then maybe a shorter duration may be appropriate. And how would you approach this patient to, like regarding CNS recurrence in
So,
adjuvant setting?
I mean, we've all
Yeah,
seen the data. We've all seen the data for the Persephone study, and that showed it was from the United Kingdom that showed that 6 months might be. It was the only one that showed that 6 months might be equivalent to
non-adjuvant.
one.
Yes,
But my
yes.
only problem with that study was that there were certain caveats. In patients who received neoadjuvant therapy or who didn't receive or who received only taxane-based therapy, it looked like the 1 year was better than the 6 months. So I still personally I think the question is still not answered. But when I have a patient that is financially striped and needs to receive anti-HER2 therapy, I do have that discussion with them. I offer them at least 6 months, very clearly stating there may be a benefit after 6 months, but probably that benefit is the most with that first 6 months. And the other 6 months might be having a benefit, but probably a lot less in these very, very small tumor sizes like the one that you presented. But I still think that the standard of care is 1 year.
Yes. Okay. Thank you. So just, like just 2 slides I put in of the APT trial, like which was, it was non-randomized, but phase two prospective trial in which weekly paclitaxel 12 and trastuzumab 12 were given and followed by 1 year of trastuzumab. So in a patient like this, perhaps you could consider that if you don't want to give anthracycline, and you could see that they had excellent, I think in the first 3 years, 100% survival, and then at 7 years, it's 97% survival. So essentially, de-escalation of therapy could be considered in a very early stage HER2 positive disease. And the other one was ATTEMPT, which is a phase two randomized study, again done on stage one patients, and which the paclitaxel and the APT arm essentially was compared with TDM1, 17 cycles, and again it showed the same responses, but the cost is obviously exorbitant. So if some patient doesn't want to have chemotherapy, then you could consider TDM1 17. Any comments before I go on to the next?
So the talking about cost, etc. Dr. Taleni presented this data with ATTEMPT, and it's very provocative because TDM1 is chemotherapy with M-tansine being the, there's neutropenia, there's significant neuropathy, particularly if continued for any length of time. The issue that someone brought up is what we now call financial toxicity, that TDM1 is exorbitant for that period of time. And unless the signal is very clear, I doubt very much that it'll be adopted as a standard of care. And our insurance companies mandate what we do often. They won't allow me to give TDM1 in this setting.
Okay. Well, this was just like a thought-provoking comment. So just very quickly, because we have only 2 minutes. So again, it's, like it's a young 36-year-old premenopausal woman and has had her surgery, and it's IDC. The tumor is 1.8 cm and it's grade 2, HER2 negative. So what would you do next? Kamran.
So the size was, how big was the tumor? 1.8 centimeter.
Yeah,
Okay.
1.8.
1.8 centimeter
And
grade
grade
2.
2.
And how old was she?
36.
36. I will offer a combined androgen blockade. I will do actually, you know what I will do is I will do oncotype DX first on her. If I can do that, if you can afford that, to decide about chemotherapy versus hormonal ablation.
Okay. So,
What
yeah.
is the size of the tumor? I think I missed that. What's the size?
1.8.
Pardon?
1.8.
1.8.
So it's a T1C.
Yeah, and grade 2. But she's 36 years old.
And what is her Ki-67?
Oh, you, that was my next question. What? So, this is what I always ask in the clinic. If I don't get the K67, I get really, but because I can't really decide. So I'm sure that all of you are using Oncotype DX or, So my question was that if you do use one of the genomic assays, like, is everybody doing Oncotype DX? Any role of MammaPrint in this setting?
So I don't use MammaPrint. I use only Oncotype DX, but I think if you used either, it's fine.
Mm,
I think Oncotype DX, MammaPrint, PAM50, I think they're all good platforms.
mm,
Uh, it's just that, Oncotype DX is one
mm,
that's number one, it's easily available here. But I also think that when you're discussing the results with your patient, because before you send off Oncotype DX, you have to have that discussion. It's so much simpler to make patients understand the whole concept of Oncotype DX compared to MammaPrint and PAM50. That's just my interpretation.
Plus,
mm.
the maximum validation from data point of view is with Oncotype DX. So
Yes.
the maximum number of studies and things we have, the data point of view, Oncotype DX has an edge over MammaPrint.
So I totally agree with that. That is our go-to genomic analysis. The MammaPrint has a little advantage, or at least they're perhaps a little step forward with node-positive disease in their MIND-ACT studies. But as Dr. Shaina pointed out, it's kind of convoluted. It's so much more difficult to explain it. So
But I think, yes, like at ASCO presented by Dr. Fatima, what I believe is that somebody who has 1 to 3 lymph node positive, clinical high, and you feel that you have to give chemotherapy, MammaPrint may be better in those patients because Oncotype DX is good for node negative, although I know that there is analysis and 1 to 3 lymph nodes, and the US oncologists mostly are more doing Oncotype DX. But in clinical high risk, MammaPrint has shown to be quite effective, especially in the postmenopausal women, and more than 40% patients didn't need to have chemotherapy because of the MammaPrint. But in this particular patient, she's young, she's very early stage. If I have to do, I would do Oncotype DX.
So I'd like to challenge my Pakistan colleagues. This lady is only 36. So she comes up with an oncotype score of 11. Are you going to be comfortable not giving her at least CMF?
I would be
That
very
is the
comfortable
thing,
not giving
like
therapy.
that was my question also because like we have to look at the age as well because in the 36 years old, somehow breast cancer is the age alone is quite a bad prognostic factor. But so we shouldn't really fix on the numbers. We need to know that even if in Taylor X the low score, but we have to combine with the clinical high risk, and then it becomes I'll not take some.
Having said that,
Yeah.
having said that, the low risk group of patients, yes, age is a very, very important factor. It sometimes trumps biology as well, in my opinion. But when you have an oncotype score of, 10 or 11, and the clinical risk is also small in these patients, I really don't see what the benefit is. I may add ovarian function suppression to them in terms of their treatment and not only give them tamoxifen, which I think will probably help them more. But it's not the question that, you want to give something, you have to give something that will actually work. And if it's not going to work in that group of patients, why give them the toxicity of chemotherapy? And Partridge, I think, has published some data looking at these young patients and their oncotype. And even in those young group of patients, if they've got a low risk, they do well without chemotherapy.
So I think less than 11 probably. Would
Yes,
you
I mean,
agree? Yes. No,
I
not
did
the
show you,
standard,
yeah,
like, yeah.
for sure.
So yes, the question was that she couldn't have Oncotype DX, of course. So next thing, I think KI67, although there is a lot of debate on that also, but as I always say, it's a poor man's oncotype. So we do use it quite frequently and find it very helpful, especially if it's very high or very low. In between ones, you could argue, depends on the lab as well. So essentially, discussion points in this case was, like how important is age? It is very important, but you need to, take into consideration the tumor stage and the biology of the tumor as well, and utility of profiling in strongly HR positive again. If you can't afford it, you can make decision based on the clinical and pathological parameters. So this is just the last slide that, like you mentioned extended therapy that you would give, more. But isn't it that Taylor X, so far the data is for up to 5 years? What about 10 years? Like, so do you start right from Taylor X and you assume that this is low risk and they will not relapse later on? Because you know that HR positive, endocrine positive tumors continue to relapse after 20 years. So what would you do at this point? The patient didn't want chemotherapy, endocrine therapy at 5 years for this particular patient. That will be my last question, and then we'll be closing the session. Dr. Smith?
So I think Dr. Shahina was very elegant in her presentation, but here again, I think our surgeons led the fray with de-escalation, and then we have followed suit with our Taylor RX and limiting chemotherapy. I think we have to look at hormone suppression at this point, okay, because it's not innocuous. In these young ladies, they're often rendered menopausal, and there is a risk of uterine cancer, albeit quite small. So going beyond 5 years in such a low stage, I think should be queried. And I probably would give the talk, but not continue. We now have genomic profiles for continuing beyond 5 years. The PAM50, the ProSigna is kind of toying with that. But Biotheranostics has something that they call the Breast Cancer Index, which looks at the risk beyond 5 years, as well as the prediction of value of hormonal therapy. Even here, it's an expensive test that's not covered by our insurance. So it's got to be a clinical decision. My clinical decision for such a young lady would be to say, consider stopping.
5 years is enough. Yeah. Okay. I think with that, we will end our session. It has been really, really informative, really good discussion. And I really thank all the speakers who came and helped me in this session. So we just have probably 5. We had a break initially of 10 minutes. So we have only 2 minutes left for the next session. So I'll say goodbye to all of you, and I'll see you soon.
Well, thank you very much. And I'm going to have to work on my plenary session because much of the thunder has been stolen by the
Shahina.
state of the art.
Yeah, and we'll also, inshallah, have you here in Lahore next year. Okay.
Thank you, Dr.
Thank you, Kamran.
Dr. Rashid.
Bye. Bye.
Bye-bye.